Ustad Hussam.
Yeah.
Your microphone.
Okay.
Oh, how are you?
Well,
how are you,
you.
dear friend?
I'm speaking from the North Coast, where I am having a vacation for the
Oh, enjoy it. Enjoy it.
and so I have a place there just on the beach. It's nice.
Wonderful.
So we're coming to join you.
Yes.
Welcome. Actually, things are getting
Yeah,
better.
I hope that we can travel very soon.
I hope so. I hope so that we meet, as you said, in person.
Yeah, sure. Sure. It's very important.
You know, the Cannes meeting got canceled, like Moody's meeting in Nairobi, that got canceled.
Yes. Of course, it's an obvious
The meeting in Egypt, they were going to have the Mediterranean meeting in Egypt. I don't think that's canceled yet.
But we will, I think, postpone it for the next year.
Yeah, we'll come next year.
Yeah.
Inshallah.
Inshallah.
Inshallah. That's what my friend said.
What is the time now? Is
It's
it
4 o'clock in the afternoon. 4 o'clock in the afternoon.
4 o'clock in the afternoon? You are in the office section.
That's right. You can see Manhattan. I showed it to Nadia. I said, Nadia, we can see Manhattan from here.
Ah, you can see.
Very beautiful.
It's 10 o'clock. It's 10 o'clock.
There's Saud. How are you?
Saud, micro.
How are you?
Thank you for the opportunity. Shukran.
Sorry. Technology. Oh, fortunately you are here.
I know. It always works out. That's what I don't worry about. You know, it's funny. We all give now. I think we're giving more international talks than before we could travel. So Dr. Spetzler was our graduation speaker. And he said, this is great. I'm in my ranch in Wyoming and I'm giving my talk from there. I don't have to get on a plane at all, you know.
We just have to wait some minutes, our two panelists from Algeria, because they have also the problem of connection with this new link.
No worries.
Sorry, Anil, sorry.
No, listen, this technology these days, you can never be sure.
Yes.
If it's the worst thing that happened today, it's nothing to worry about.
Anywhere.
And
hello, everybody.
Even in the countries, huh?
Hello, everybody.
Hello, Saud. How are you?
Hello. Can you see me?
Yes.
We want to see the ocean. We want to see the view of your house, but it's a
Okay, I'll give you a view. That's the garden. Can you see that?
Yeah.
Yes, we can see that. It looks beautiful.
Yeah.
And then far are the palm trees and the swimming pool, and then the Mediterranean.
That's right. I can see Malaga. I can see Miguel. He's
So
Saud, about 30 minutes is fine time-wise. I want to make sure. If you want to make it shorter.
Yes, it's okay, Anil. Okay, thank you. Monsieur Abdelbi, c'est bon, vous avez, je vous ai envoyé le mail. Je viens de vous envoyer, ça fait 5 minutes que je vous ai envoyé le mail.
That's one of the great regrets of my life, Saud, that I didn't learn French.
But you know so many things, Anil.
You can, it's not.
You can, I'm sure with few courses, you will talk very, very well the French, I know. Because you have some capacities, so I'm sure that you will do that very well.
You know, Charles V used to say, I pray to God in French. I speak to my wife in Spanish. I speak to my mistress in Italian, and I speak to my horse in German. Never cracked this in Germany, but I thought that's a great line.
Nabila, is Professor Abdin be... No?
Okay.
وين مشى عندك بالبلا شوف انا رسلت لك ان اوتر ميل باش هكاك ما تتخلطلكش كليكي فوقه صايي vous l'avez trouvé allez ça marche très bien d'accord ça
Bonsoir.
So I told Nadia I'm drinking green Moroccan mint tea.
No.
Where you find the mint in New York is of course there is
It's
many.
very popular. Moroccan green
Yes, I
mint
know.
tea is very popular.
Very popular, sure.
Anil,
Yes.
if you want Moroccan mint tea, you go to the Queens.
Oh, really?
Yeah, really. Really, there is community of the city which is near Casablanca. The name is Mohammedia, and a lot of people from Mohammedia are living in Queens.
You must send me that. You know, I was born in Queens. My parents lived in Queens.
Yeah.
So, in Jackson Heights, yeah. Now, Malika Oufkir, Stolen Lives, she was from Morocco.
Yes, yes.
She's a
Why do you
controversial figure.
remember
Nadia
only
tells me.
You know her?
Why you just remember Malika Oufkir, but the other things more interesting about Morocco?
I
Malika
know.
Oufkir is not the best thing that we have to remember.
I read that
Sorry,
book,
that's-
but Nadia told me that book was one-sided. I'm like, okay.
Sure.
Exactement, oui, oui, ben c'est ça, c'est ça. Oui, 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 oui. Comment ça choisir? Non, comme moi, quand j'ai cliqué, je suis rentrée dedans.
I like that, right?
Absolument, c'est très, très long. Vous l'avez trouvé à la fin du mail?
Tertiary, do you hear me? Thank you.
Si, moi, je vais mettre admettre. Vous êtes sur la salle d'attente.
Non, c'est bon, j'ai mis.
Non, parce que c'est comme ça, c'est normal.
I like this painting by Ordia Hamag. That's a great painting there.
You are talking about my painting?
Is that your painting or Dia Hamag? I like that one. I like your painting too, the sea.
No, yes, it's a ship in the sea with, I don't know how we say it in English, tempête. Comment ça se dit?
Storm, storm.
Storm.
Tempest.
Yeah, it's a very, very big tableau. Je sais pas comment on dit. Yeah.
Painting.
Paint, yes, it's very big painting. I think that Professor Abdenbi is okay. Professor Belebna is here, I think, also. Nabila, do you see Professor Abdenbi?
He's trying to be admitted, but I think there is a problem with him. Il n'arrive pas.
C'est marqué jonction en cours.
Problème de réseau, de connexion.
I think. So maybe we have to begin because we have now near 50 minutes. Ça y est, Monsieur Abdenbi? Ça y est, vous êtes rentré?
We can wait, no worries.
Ça y est. Oui, Nejia.
Oh, it's okay.
I think he's here. Professor Abdenbi. Monsieur Abdenbi. Monsieur Belebna. Bonsoir, Monsieur Bouyoussef.
Bonsoir, Kherdin.
Bonsoir, comment allez-vous?
Bonsoir, Bouyou.
Bonsoir.
Bonsoir, Hussam. Bonsoir, Hussam.
Bonsoir. How are you?
Fine, and you? It's a great pleasure for me to see you this evening.
It's my pleasure, wallahi.
Wallah. Ça va, tout le monde va bien?
Alhamdulillah. Et toi?
Alhamdulillah.
Alhamdulillah.
Nabila, ça va?
Ça va.
Abdullah, Abdussamad, Najia, tout le monde?
Ça va, Habibi, ça va. Ça va, tout va bien.
On espère traverser
On t'embrasse.
sans problème.
Nadia, I like the mirror in the background. Your mirror looks good there.
Oh, thank you. I am in my, beach house. I can't show you my, because it's 9 p.m. It's already dark.
Dark,
So
yeah.
I'll show you the oceans, the ocean Atlantic. you know about Anil, you have been there ever?
No, I only saw the movie Casablanca.
Oh, you only see the movie? Okay, so
I've seen the movie 4 times. I love that movie.
You should to visit us next time. I hope next year, because this year we will just postpone our meeting, but we are organizing maybe a course, African course in November. We are just talking and deciding about that. I will send you in as soon as possible the dates and of course all the information about this course. I hope that you can join us in Rabat.
So the Pan-Mediterranean meeting in Cairo is still on, or is it canceled?
Cancelled.
Oh, canceled.
No, No, it's canceled for this year, but I think we will postpone next year.
Everything is canceled for 20.
21. Yeah, 21.
You know, I worry about the World Congress in Colombia because you know, the attendance may be really poor for that.
We don't know because we don't know what happened in next year. But sure that I think it's they will have some problem to have a important attendance. Sure. So Ed, are you here? Nabila? Algerian Society?
Some technical problems, but
yes, it's happened sometimes.
Nothing to worry.
Hi, everybody. Hi, colleagues.
Hi, Tleba. How are you? Comment tu
Fine, fine. Thank you. Merci. Merci, Abd Samad. Thank you. Hi, Najia, Souad.
Hi, how are you?
Nabila.
Sohail, tu as reçu le lien de demain du CDS?
Yes, yeah, bien sûr. J'ai reçu, j'ai confirmé.
Très bien.
So, dear colleagues, I think that we will begin. We are very late. I'm so sorry. You know, it is technology. Professor Abdenbi, we will solve his problem of connection, but we have to begin our webinar. So first of all, I want to welcome everybody. And of course, first of all, I want to welcome Professor Anil Nanda and thanks him for accepting the invitation. This webinar is organized by the Algerian Society in collaboration with the Pan-Arab Neurosurgical Society. And of course, it's a great honor to have Professor Anil Nanda as a guest speaker and also our panelists from the Pan-Arab Neurosurgical Society with Professor Benaissa Abdenbi, who will join us. He is past president of Pan-Arab Neurosurgical Society and also honorary president of the society. He is one of our deans in neurosurgery and our leader in functional neurosurgery. We have also Professor Hussam Al-Husseini from Egypt, who is also a past president of Pan-Arab Society and honorary president and very well known in Arabic neurosurgery and also African neurosurgery. And we have also Professor Abd Samad Al-Azhari, very well known neurosurgeon in Arabic world and in African neurosurgery. And I just want to remember that he has the Medal of Honor of the WFNS in 2017 in Istanbul. He is very active in African and Arabic neurosurgery. We have also Professor Belibna Bashir from Algeria. He is one of our colleagues in Algeria. He is head of department of one of the biggest departments in Algeria, in the west of Algeria, in the town of Oran, which is at near 400 kilometers from Algiers on the Mediterranean Sea. And so welcome to everybody. I will give the floor to Professor Najia Al-Abadi, who is the president of Pan-Arab Neurosurgical Society. I think that everybody of you know her very well. And I just want to say something because I'm a woman. And I just want to say that she is running for the post of president-elect of WFNS. So Najia, please could you introduce our friend, Professor Anil Nanda? Thank you.
Okay, I will. I hope that I can do it, but I'm sure that I will do it because he is very known. Thank you, Suad. First, let me express my congratulations and deep thanks for Algerian Society for this great job that you are doing, and especially the board with Professor Suad Bahti. Are you hearing me?
Yes, Najia, I just want to tell you that Professor Abdel B could join us, fortunately.
Oh, okay. So he will introduce our guest speaker. So just I will have give just a small word about our colleague from the Algerian Society to thank them, to congratulate them for this great job, fantastic job that you are done. And I hope that every society can do it as well. And of course, it's give me a great pleasure today to be associated to this webinar with as Pan-Arab societies with many outstanding colleagues that you introduced, Suad, just a few minutes ago. And we are, of course, very happy to have this great collaboration between, of course, Pan-Arab countries and societies from the Pan-Arab area with the Pan-Arab societies. And of course, this is a great pleasure to be today with many colleagues from Egypt, as our former president, Professor Hussam Husseini, is on vacation, and he is with us today. Thank you so much, Hussam, for being with us on today, and every for as usual, of course. And of course, our friend from Arabia Saudi, he is here. Suad, I don't see here.
No, I think he has also a problem
with, but I think he will join us, and I would like to thank him.
Maybe.
And thank, of course, the Arabian Saudi Society to accept our invitation and to be as a panelist. And finally, let me express my congratulations and my thanks to our guest speaker to accepting our invitation. And he is well-known neurosurgeon, and of course, the topic from today is, you see here, it's about skull base, and the title of the topics it's very special. And Anil, his usual give us very special talks about neurosurgical. He's very well known around the world, but he's also well known with his particular philosophy, particular humor, and many wonderful things. Thank you, Anil, to be with us today. And thank you, Suad. Really, it's a good series of webinars that you are organizing. And we are proud of you also. Thank you.
Thank you. Professor Abdel B, fortunately you can join us. Did you hear me? Nabila. Professor Abdel B.
No?
No. Unfortunately.
Our guest speaker today is Professor Ali Nalda. I think all of you know very well Professor Anil Nalda. He is well known in around the world. He is, of course, from USA. He is working now in New Jersey, but he had a huge and tremendous, of course, career before in many others university. And he's, of course, you know him, I think, very well through our meetings when we attend the meetings in WNS. He gives the fantastic and outstanding talks in many, of course, meetings around the world, especially in WNS, but of course in the many others meetings of WNS and others, of course. So he will organize many also meetings, and the next meeting that he will organize is in September in New Jersey, about a global neurosurgery. He is not only very well neurosurgeon in the skull base and many fields very important, but he's interested in the topic with on the global neurosurgery. And we hope that we can join your meeting in September, of course, all. But I know it's virtually, but we are expecting that we can see you personally as soon as possible. Thank you, Anil, to be with us today, and you have the floor. Maybe if Suad, you want to add something?
No, just want Anil give him his talk.
Okay.
Thank
Well,
you.
thank you so much. Thank you, everybody. You know, it feels like family. You know, we're all far apart, but it's great to see familiar faces. And life is short. I think one thing COVID has taught us, that life is short and it can change in a second. And so we're always grateful to everyone. We're grateful to our families, to our friends, and the neurosurgical family is a great blessing. So thank you all for being here. Let me see if this works. So, you know, we live in a time of Corona. These are the latest 16 million cases. This is a tragedy, 600,000 deaths. And a lot of neurosurgeons have died. You know, Jim Goodrich was one of our colleagues. He passed away. And then Dr. Vinatku was the first female neurosurgeon in Indonesia. She passed away. So we've lost a lot of friends, but I want to thank the Algerian and the Pan-Arabic Society for having me. I will say one thing about leadership in women. If you look at the COVID countries that were run by women, Angela Merkel, Denmark, Jacinda in New Zealand, they had the best COVID rates. So we need more female leadership, okay? That's all I'm gonna say. I think that's the point. I'm not gonna talk about our president, but I just leave it at that. You know, I'm a big fan of Algeria. I think Albert Camus, I loved his book, The Stranger, and I love that line of his always. And I read this line during COVID. In the midst of winter, I have found there was within me an invincible summer. And that's true for all of us. I also love the Mersal investigation by Kamel Daoud. And it's interesting, the Battle of Algiers, that movie is a classic. It's a great story, but you know, I think like Vietnam was for America, Algiers was for France. And I think it's an interesting story. When the Gulf War started, every US troop that went to the Middle East was made to see the Battle of Algiers. So it's an educational time. And again, I think the cultural, I didn't realize Algiers is the biggest country in Africa. You've had Nobel Prize winners and great art. So we are very, very fortunate to be. So I feel in spirit, I'm in Algeria today. So it's a wonderful feeling. I've been very blessed. I've operated over close to 18,000 surgeries. And so I've done a lot, and, you know, I learned a lot and made mistakes, and my interest is in skull base and vascular. And I always like anatomy. I think that's what Professor Rotan taught us. You should know anatomy for all the residents and the younger. I think skull base anatomy or any anatomy is really, it's the religious basis of what we do. Much like the Quran is to Islam and the Bible is to Christianity, anatomy is the basis of our religion, which is neurosurgery, which we worship. So I think that's very important to have. And what I'm going to do is take you on a quick tour of cranial base and tell you where I made mistakes, what I learned from them, and where we can get better. So I'll take you from the anterior cranial base to the middle fossa, to the posterior fossa, to the foramen magnum, and sort of look at each of our things. In the middle, I'll take a little diversion to vascular. So this is close to, you know, now close to 180 anterior cranial base meningiomas, largely women. Remember history. Durante is the first person to report an anterior cranial base meningioma, and the patient lived for 15 years. This was reported in the Lancet. So it's a great case to show how it all started. And these are some of the cases. This is if somebody was admitted for dementia for 6 months in Louisiana, and they did a CAT scan and they found this. And she went back home. She did really well. I tend to do everything from one side. If I can do a carpal tunnel from one side, I'll do it from one side. So I'm very biased on that. Most of my tumors, I will come unilaterally. This was a study we did at all olfactory groove meningioma. We showed that the signal change was much lesser if you went unilateral rather than bilateral. Now, we didn't do neurocognitive testing, but we still felt that was important. We published this. I think Tomasello published this as well. And we showed clearly that there was a subset of tumors. You went from the side, you tend to have better outcomes. Here's someone else, and even on this case, I did not go from, I went unilateral. And what I did is I cut the falx and it pulled everything out that way. So I feel that that has helped a lot. To show you the intraoperative pictures, and you can see he lost 50 pounds after this surgery. So we tell people you don't need to get your stomach stapled, you need to get your skull-based tumor taken out, and you'll lose all the weight in the world. Yeah. So when we look at tuberculum sellae meningioma, we worry about vision. So this is an important thing to worry about. And you know, with the more endoscopic approaches, we want to make sure that our results are documented well. And in my series, I did have 4 cases that their vision got worse. So that's important to talk about that, you know. So you can see here somebody from the right side, we did pterional craniotomy, and I'll take the video right up to the end. So you can see this is the internal carotid artery, anterior cerebral. Again, no touch technique. I really don't like to touch the optic nerve, and around there, I don't use any heat at all. Because I've seen sometimes small tumor, any touch of bipolar, and you'll lose optic vision. So here you can see last piece, optic nerve completely open, no touch, and his vision was really good. He did very well. So again, with those cases, I think the other thing you need to talk about is spinal fluid leaks on these cases. You know, the data, we have to publish that data. My CSF leak rate was about 1.2%. In one case, I had to go back to reoperate. So it's just something you should be aware of. This is the cavernous sinus. You know, I've been hounded by the cavernous sinus. Initially, I was very aggressive. I would do aggressive resections, get into the cavernous sinus. And then I found the morbidity was quite high. And this is where resisting the siren song. You want to resist this and say, you can go for broke, but you might hurt the patient. Just to give you some historical background, we published this paper on the history of Winslow and the name cavernous sinus. He mistook it for a urology organ, and it was probably a misnomer, but it was a nice historical piece. This was my series of meningiomas, 65 skull-based cavernous sinus meningiomas, presented with headaches. This was on a cover. And you know, a soft meningioma on the cavernous sinus is a dream, but that's a rarity. That's never a problem. So here you can see this is a soft tumor. It came out really well. But this is not what happens most of the time. Here it is. Everything is cleaned out. You can see all the way down back to the posterior fossa, but everything came out. This is an exception. This does not happen all the time, okay? We had a complete resection, but this is rare. On a case like this, you have to resist the siren song. You can't say, we're going to do this, do a bypass graft and take this whole thing out. The morbidity is too high. So what we have learned with these cases, if you leave this residual behind, in either your gamma knife or you observe, your quality of life is much better. And that's so important that you worry about quality of life. This is our series. We had a 5-year follow-up. And what we found was if we radiated up front, they have much better control. So you can see if they were asymptomatic and they got radiated, this shows you the hazard function. This is the recurrence rate. You didn't radiate, it was a much higher thing. If you radiated, it was much lower. So our philosophy now is with small, stable residual, we consider gamma knife and we take that well. So this was our series, but even in this series, we didn't have a 90% resection rate. It was only 41.5%. So again, it goes to the title of this talk, we resist the siren. We don't say we're going to go for broke and take everything out and then you have issues. So I think that balance is important. Yeah. This was a new paper that Lunsford just printed out in the Journal of Neurosurgery. I mean, they had 95% control rates. For small meningiomas of the cavernous sinus, I agree with Dr. Lunsford. I don't think we need to go in. If you can empirically gamma knife them, it is not worth going and doing a biopsy for this. And I think the results are very good. And that's what we have done as well. Sometimes you can get confounded. So this is a tumor in a young boy. He was a baseball player and he presented with a 6th nerve palsy. And I felt a little uncomfortable just gamma knifing it. There was a cyst in there. And I'm like, this doesn't look like a classic meningioma. So we actually operated on this, got into the cavernous sinus. I'll show this to you. And this turned out to be a schwannoma inside the cavernous sinus. So we can see here, it was a nice encapsulated lesion that we were able to peel off. You can see that beautiful resection of this. And this is one of the rare cases I've seen. His sixth nerve was gone post-op right away. So we got a gross total resection. He was a baseball player. He wanted to go back to playing baseball in college. But sometimes you get lucky, and you can see that. No deficit, MRI completely clean, and he's done very well. I want to talk about aneurysms. I was at a meeting with Najia, with the global meeting, and she said in Morocco, 80% of the aneurysms still coiled. I said, I'm ready to move to Morocco. I've clipped over 1,000 aneurysms, and I miss the wonderful days when we clipped them. Right now in our institution, 70 to 80% of the aneurysms are coiled, 20% are clipped. And I think the national ratio in the United States is obviously more coiling than clipping. And this is a classic case that I would have done open. This I did about 8 years ago. And I'll skip the video in the interest of time. This is dividing the falciform ligament. See, I can show it to you quickly. We put a bunch of side angle clips on this. And then we did an angiogram, and the learning point here was sometimes when you do these angiograms, you think the ICG and you think it's gone, and the tumor was, I mean, the aneurysm was not gone. So let me show this to you. So we got all these clips in there, and we like, okay, this looks good. We did an ICG, and you can see the carotid filled up, but I didn't feel good about it. And I said, let me just go ahead and do an angiogram. We did an intraoperative angiogram on her, and guess what? The carotid was completely blocked. So I pulled out one of the clips, the more proximal clip. You can see I pulled that one out, and then the carotid opened up. So this skill set is important, but I don't know if it's going to be useful anymore. We published our series on giant aneurysms with really good results. And then, you know, this was my favorite case, the basilar apex aneurysm. So we have really not clipped one in about 5 years. I do superior cerebellar ones, but our endovascular colleagues have taken over this. Quickly, to move into acoustic neuromas, you know, I think acoustic neuromas, everyone sees large ones and small ones. And I think facial function is really important. You can see here a perfect smile. We always want that. And I will tell you, in large acoustics, more than 5 centimeters in my hands, even if I've saved the nerve, sometimes the function is not perfect. So these are psychomotor skills that you really have to be very cautious with. And you know, people say, oh, 6 centimeter acoustic, we saved hearing, we saved facial nerve. I'm not that sure. Sometimes we don't do as well on that. So this young girl was going to get married. Fortunately, her nerve was perfect. 6 months later, I tend to leave a little bit of tumor. So you can see this one is one of my partner's family members. I left very small amount of tumor on the facial nerve. She's done well. She's about 9 years out. So coming from there, I think we should talk a little bit about petroclival meningiomas. After basilar aneurysms and large acoustic neuromas, the tumors that keep me up at night are petroclival meningioma. Also large AVMs. If there's signal change in a petroclival meningioma and T2, that worries me because you could do technically a perfect job and still have problems. So here are the approaches I use for petroclival meningiomas. So you can see the presenting symptoms for these: facial pain, double vision, ptosis, blurring of vision, but headache is one of the commonest symptoms with petroclival meningiomas. So here's somebody with a petroclival meningioma, had some dizziness, and these are the intraoperative pictures. I'll just show you the videotape. You know, when this is the tentorium here. Tentorium's here, petrous bone is here. I used to do petrosectomies on these tumors, and I moved away from that. Here you can see it's a soft tumor. When it's soft, the gods are good to you, okay? So we're in that arachnoid plane, much like doing an acoustic. You can see superior cerebellar there. This is 7th and 8th cranial nerve complex. We're moving in between, removing the arachnoid. And now we're peeling it off the brain stem. But when it's a soft tumor, it's much easier. There you can see, you just saw a hint of the trigeminal nerve, which is really stretched out there. Very splayed out. And now we're going to go superiorly. Again, arachnoid coming down. Once we go superiorly, we'll see the trochlear nerve. This is the apex of the tumor. Devascularized completely. And you can see the brain's really relaxed. And she did very well. Now, if you notice, there is some tumor in the cavernous sinus here. I gamma knifed this. I gamma knifed it 6 years ago. She's done really well with no problems at all. But I wish every time people would do well. This was a physician that I operated on, petroclival meningioma. I went transpetrous, I debulked, but I left tumor. Even though I resisted the siren song here, you can see this guy had a facial weakness. He had difficulty walking. He never worked as an ER physician again. So sometimes, even if we try and do a good job and be conservative, we don't get great results. So this was the editorial we wrote on resisting the siren song, when to stop, when to get away. It's like in the Achilles, in the Iliad, Achilles must choose between Nostos, which is a safe journey home, or glory, which is, I got a great looking post-op MRI, but the patient doesn't look good. So those are things we face. I want to talk about complications because I wish we could say, oh, everybody does great and just show our triumphs. But every neurosurgeon knows that the big man in heaven sometimes he humbles us with complications. And you never know when it comes. So these are all my complications: third nerve paresis, hemiparesis, facial numbness. Here's somebody with a young mother with 3 children. And she said, you know what, I can't have any deficits. And I did a subtotal resection on her about 16 years ago. And you can see this is the tumor I left behind. I gamma knifed this, and you can see 15 years later, it's completely shrunk. And she did very well. Her eyes were normal, and again, she lost weight over 15 years. You can see she's done really well. So what do you do with these large tumors? Initially, I would have done a big petrosectomy on this. This woman was hemiparetic, and she'd failed her swallow test, so she wasn't doing well. We went retromastoid on this. You can see this was a firm tumor. It wasn't that soft. Debulked it. But then I had a lot of trouble when it was in the brain stem. It was a lot of adherence there. Wasn't doing well, and I stopped. And then I came back, and I came back subtemporally, and I got all this off. And then I left a little bit behind, and we gamma knifed this, and she did great. So quality of life is important. We resisted the siren here. We didn't go for broke, and our outcome was good. So I think that balance is very important. We published our series on petroclival meningiomas, which showed that our resection rate wasn't that great, but our outcomes were good. So again, that balance is very, very important, that we make sure everything is okay. Now, when you come to the foramen magnum, these are very fibrous tumors. I've never seen a soft new tumor in the foramen magnum, and I think it has something to do with motion. I've seen Mets there that were soft. This first description was from Halapou, from Hospital Larry Bogier. I think it's so interesting. The first foramen magnum tumor was described there, and Bernard George was sort of the expert on foramen magnum tumors, and he worked at Larry Bogier. So you can see here, this is the approach, again, cadaver dissection. These are tumors, they come out relatively easy. Here's another one, she was 82 and quadriparetic, and we resected this, and she actually did well for 5 years. So we think all these systems help. We actually published this where we showed that you don't have to take the condyle off, that you don't have to go that way out lateral, and you can get a decent resection. So when we looked at all our Simpson grades for my personal series of meningiomas, close to about 500 meningiomas, and we looked at the grade ones and how they worked, and we looked at all these locations and stuff, and I published this, and at that time, Dr. Simpson's grade was alive. I thought he didn't live anymore, but I think one of the great blessings of academics is you get a letter like this, and I got this letter 4 years ago, and he said, I'm 89, I'm in frail health, I had a hemiplegic stroke, and he said, I liked your paper. This is what we live for. These are the great moments in academic medicine. We're like, oh my God, he read the paper, he's still alive, he passed away, but a great guy, and I think we still all use Simpson classification. So we looked at our skull base, we looked at all our classifications, grade 1, grade 2, and it really correlated very well by grade. And you can just see that there. You can see here, grade 1, recurrence rate 7%, and then it kept sort of, the total number of cases showed that. But complications are humbling. So this is Gilgamesh, who said that if a physician treats a patient with a metal knife and causes the patient to die, his hand shall be cut off. If he followed this rule from 4,000 years ago, no skull-based surgeons would have hands because we've all had mortality. And I've had my share, leaks, hemiparesis, facial numbness. This is the famous Dr. Liston, who did an amputation, and he did the amputation, he cut his assistant's finger, the patient died, his assistant died, and a woman watching the surgery had a cardiac arrest, and she died. So every time you feel bad with the mortality, remember, this case had 300% mortality because 3 people died. So it's a good way to stay grateful. So this really was the subject of my talk. When Odysseus is going through the sirens, he is so tempted. So they said, tie me up so that when the music comes, I won't listen to them. And I think that's so important, this cognitive dissonance where we go, no, we must go for broke. I want a good looking post-op MRI, but how good is your patient gonna look? So we always struggle with this balance as to what is the right thing to do, where we stand with this, and I think I personally struggle a lot with it, when to say no and when to keep moving. So I like these. This is a beautiful personal portrait of Rembrandt, and you can see the thing I like about him is that look at the honesty with which he portrays himself. He doesn't show any Botox. He doesn't give himself a facelift. This is the way he looks. And I think the lesson is all of us should learn from Rembrandt. We should be very honest about our complications. Say, geez, this could happen to me. It could happen to anybody. And I think you have to be like this. And even though we could see Malaga from across the Mediterranean there, I don't think Picasso's self-portraits are a good way for us to go. They're great art, but perhaps they get us confused, yeah. So I will show you things that have gone wrong. This is a transphenyl that I did. It was really good. I got most of the tumor out. And I was, like ready to go home. And you can just look at the carotid artery there. And we're taking more tumor out. And right when we're doing this tape still makes me sick. So you can see there's a carotid rupture. I sutured the carotid, but the outcome was not good. And I think all of us go through this. We get complications, and in the best of hands, these things happen. This was a petroclival meningioma, had a beautiful result, no deficit. He got C. difficile in rehab 3 weeks after surgery and died of sepsis. So I could say, gee, I did a great operation, great pre-op, post-op, look at this picture, it's moving everything, but I still lost the patient. So I think we have to be honest about that. And this is the great René Leriche. I'm sure this quotation is in French, Saud, so you can, every surgeon carries about him a little cemetery in which from time to time he goes to pray, a cemetery of bitterness and regret, of which he seeks the reason for certain of his failures. And I think we all have cemeteries in which we go to pray. We say, geez, what did we do wrong here? And these complications are just not limited to open surgery. This is a gamma knife. You can see the acoustic is right here, and they burnt a hole in the peduncle, okay? This was 6 patients in Chicago with a radiosurgical system for trigeminal neuralgia. They gave them 10 times the dosage for their brainstem. And all 6 patients died in 6 months. Their brainstem was completely destroyed. So I think I tell the residents always, this is Czesław Miłosz, the great Polish poet, in a room where people maintain a conspiracy of silence. One word of truth sounds like a pistol shot. We want the residents and the younger people to be that pistol shot. They need to tell us you were out of line, you didn't resist the siren song, you moved on. And sometimes it's best to do nothing. So you can see here, this is a petroclival meningioma. If I saw this patient when I was younger, I would say, oh yes, I can do a petrosectomy, I can take it out. I put a shunt in this lady, she's now 6 years out, no problems at all. This is a burnt out meningioma, doesn't need surgery. And so I think, you know, with knowledge and experience, you get neurosurgical wisdom. And that wisdom, you always, you know, you never know where you get it, when. And I think gamma knife is still an important adjunct. This was somebody with small skull-based meningioma with gamma knife, and he did very well. So sometimes skull-based surgeons are from Mars and radiosurgeons are from Venus. But our goal is never to do harm. The last thing we want to tell a patient is your surgery was completely unnecessary. You didn't need it. And so this is an acoustic I've followed now for 10 years, never grew. So sometimes it's better to leave it alone. This is a small meningioma. You can see that it's grown very little. So if I'd gamma knifed it here, you'd say, oh, great triumph. But it really hasn't grown. You know, it's almost 20 years now. So to summarize, these are all sort of my cases that I've operated on. These are all the papers I've written about skull base, on petroclival, far lateral, tuberculum cellae. And so I think when you end, you talk about resisting the siren song. I think anterocranial base, clinoidal, diaphragm cella, foramen magnum, it's easier to get gross total resection with low morbidity and mortality. I think cavernous sinus meningioma and petroclival meningiomas, I'm a little more cautious. I try to resist the siren song and to play safe to get good outcomes. And I think Simpson grading is still a very important prognostic value, and complications in skull base are still very serious. So I don't want you to think, yes, you know, I've done a couple of hundred of these and everybody does great. I think we all need to be honest about that. So now, and finally, I want to invite all of you. This is going to be just registration only. It's free for students. I think it's a very nominal registration. We're going to have great speakers, Spetzler, Sami, all of them are going to speak. So we would like and encourage your residents to come. It's going to be in New Jersey, and it's going to be a great meeting. And I thought I would end with this beautiful COVID slide. This was in the New York Times. These are people from Bergamo, where the epidemic was at its worst. And Gabriel Massoni, he was the intensivist there. And he said, I thought of the words of Jean-Paul. It is necessary that the heroic becomes daily and that the daily becomes heroic. And this was one of the grandmothers. There's an intensivist, Roberta Terzi, once again, female leadership to the front. And she said, you know, do I really want to go into retirement to be with my grandchildren on a day like this? And my answer is, I want to be there at the side of these patients. I want to be with these patients and I want to heal. And with those words, I want to thank all of you for giving me this opportunity. It was great to be here. I feel in spirit, I was in Algiers and it's a wonderful meeting. So merci beaucoup. I appreciate this opportunity.
Thank you so much for this outstanding presentation, Anil. As always, really, thank you so much. So now I will give the talk to Professor Abdenbi. Fortunately, are you hearing me, Professor Abdenbi? Microphone. Microphone, please. Micro. Micro. Nabila, tu peux pas le lui lâcher?
I also want to acknowledge my fellow, Dr. Barat, who helped me with this talk. He's on today, but I appreciate that.
Okay, thank you.
I can't do anything without the fellows. They publish, they do all the work, so I'm very grateful to them. They edit all the videotapes, so very, very grateful to all of them.
Professor Abdenbi, are you hearing me?
I don't think so.
No.
Hear you.
So, Professor Azhari.
Hi, okay. Thank you, Suad, and thank you for all colleagues of Algerian Society.
Ah, voilà, très bien, pardon. C'est bon? Est-ce que vous nous entendez?
Vous m'entendez?
Oui, oui.
Et moi, je l'entends bien. First, sorry for my delay. Second, congratulations, Professor Anil Nanda, for this wonderful presentation and overview of the surgery of the skull base. Good afternoon in the United States and good evening in Europe, Africa, and Middle East. I think, as we have seen on slides, among the last slides, the experience of the surgeon, the number of years of practice, and the number of cases allow him to realize radical removal, complete removal of some tumors of the skull base. And I think to tuberculum cell meningioma, we are very happy when we operate these patients, and the patient is also very happy after in the postoperative outcome when he not visual acuity improved. But the difficulty is more and more we go to the posterior part of the skull base, and also for some histological types as chordoma, chondrosarcomas, the difficulties
Increase.
Yes, increase. Thank you, my friend Abdel Samad. So maybe the point of discussion with you, are we sure that radiosurgery as adjuvant therapy in this lesion, and I talk about the tumors, not the vascular lesions, are without bad consequences for the neighboring structures and especially for the brain? Because some of neurosurgeons, experts in the world, and talk every time about the radionecrosis following radiosurgery. What's your opinion?
So, you know, I mean, if you talk to Dr. Lunsford, he will tell you everything needs to get gamma knife. If you talk to Professor El-Mefti, everything needs to come out. And always the truth is somewhere in the middle. You know, if we say we have a monopoly on knowledge, then we don't know what we're saying. I have always tailored it, you know. I can tell you from my data, and this is from Karolinska and from us, you know, small residual meningiomas, if you do upfront radiosurgery, the control rate is better, but it doesn't mean it's mandatory. Some patients of mine don't want to still get gamma knife. I'm like, no problem, we'll watch it. So I agree with you. Some of this is sort of wisdom, you know, where do you draw the line? What do you feel comfortable with and not, you know? I kind of towards gamma knife, you know, if I leave a little residual, I just think I balance that. But I also think we should be very cautious. We say 100% resection and you have great post-op MRIs, the patient's got a trach and a G-tube. Then I don't think we've done any favors, you know? So I think in all these discussions, you have to leave the ego outside. And you have to say, what would we do if this was our family? If this was my wife or my daughter or my mother, what would I do? And I think that always tempers it very well, because then you do the right thing. And sometimes, you know, we still make mistakes. If this was a perfect science, we'd all be mathematics professors. We wouldn't be neurosurgeons, you know.
Another question, I would like to know your policy in front, in case of patients aged 50 years and they haven't any functional sign, only maybe some headaches and without physical signs. And on the CT, on the MRI, this MRI depicts a tumor around 5 centimeters. I repeat, without presenting signs, without functional signs, only some headaches. What do you do for these patients with tumor with the big diameter around 3 centimeters?
I watched those. I mean, I don't think there's any data to say that we need to be aggressive. I showed you a petrous meningioma in a 67-year-old lady with that hydrocephalus. I watched her for 6 years. I think observation is very important because the tumor will declare itself. If it's a fast grower, you'll see, okay, we have to intervene. It's slow and it's not growing. It's growing 1 millimeter a year. You can leave it alone. So I really play by ear, but my gut instinct always is to watch and see how they do. They're asymptomatic, they don't have headaches. That's why I think it's still an art. Judgment is an art. It's not a mathematical thing. It's not an algorithm that you say, this is the only way I'm going to do it. You know, I showed you a case of a young girl, a woman with 3 children, and said, I can't have any, I'm the sole breadwinner. And I was manic. I didn't want to get any deficit. She did, you know, so I think those are things you balance well.
Professor Anil Nanda, thank you. And maybe Professor Abdessamad Al-Azhari have some comments or questions.
Thank you. Thank you. I would thanks Professor Nanda and thanks the Algerian Society, Saad President. Also Nabila, we haven't to forget that she organized everything, and all the committee of the Algerian Society. Thank you to offer the opportunity to see Anil Nanda and also to see Moroccan, Arabic, and Algerian colleagues. I sometimes hear to Anil in every year in World Academy, and I like your presentation because you make sometimes some ingredient of philosophy and with some. So I have some comments about that. You are very right when you said it's facilitate vascular surgery. And one in Casablanca, when we started the program of vascular surgery, I said always to my colleagues that vascular surgery facilitates the skull-based surgery. And I think I don't know how is your opinion. I think that's the vessels are the devil heads behind the tumor. So if you do vascular surgery, you fight the devil directly, and you know him, and you can know your enemy. But you are right. It's the same. Vascular surgery facilitates skull-based surgery. Skull-based surgery facilitates vascular surgery. And my question for you is, it's actual now everywhere in the world. My friend Abdel Ibn Isa talk about that. It's gamma knife. Don't you think that gamma knife push you to forget the song of the siren? Because you are not, we can make the new generation very lazy in
I agree.
this way. So do you think that it's positive, or what is your opinion? Because now everybody said, I can let 2 centimeters. the tumor and let it to gamma knife, and he don't go to the end of the of his goal. What is your opinion, Adil?
I agree with you. It has made us technically lazy. See, when I worked with Janetta and we closed the posterior fossa, if we got a leak, my God, he would just look at us. And I'm like, I remember I started my fellowship with him and he would do like 15 MVDs in one day. So I was running one of his rooms and I got 2 leaks in the first month. And I was so guilty. I never got a leak after that. I would put multiple stitches, I'd close it. I was very technically, good on that. And then what happens is the glue comes along, okay, to seal and all these glues. And now I see the residents, they're not closing it tight. They're not doing a perfect job. I'll put some glue there. And you're absolutely right that we're not pushing the envelope and maybe we're becoming technically lazy. Or like, okay, leave some tumor behind with a gamma knife. So I agree with that. That's a very honest criticism on that. And that's what I tell the residents. I said, you must aspire to technical perfection. It's like, intra-op agram shows you that the aneurysm is gone. It's not like a dog ear there. So I think in vascular, it's easier to get that. I think with skull base, where to stop is something I still struggle with, and I don't know the right answer, but I agree with you that perhaps gamma knife is making us technically lazy because once we're down to 2 centimeters, we're like, we're not going after this. But I still go out with acoustic. If I can take the whole thing out, I just took out a physician's acoustic where we took out everything and perfect results, good facial nerve function and everything. So I think you have to aspire for that.
Thank you. Thank you.
Saad, may
Please, we just have to give the talk to Professor Hussein.
yes.
Yes.
Yes, thank you, Professor Saad, for inviting me. And that was a great, honest presentation from a great surgeon with great experience. I think the message here is when to stop. And you need to have an excellent result, but still an excellent patient as much as possible, and to avoid as much as possible complication. And here comes the gamma knife. The other thing I have noticed in the presentation that the traditional approaches still have the biggest role in skull base surgery. Actually, I was trained with all these petrosals, orbitozygomatic, anterior petrous, but I think still we can do the same with a unilateral subfrontal, a good terional, a suboccipital, and even do it in a stage surgery. The other thing I want to ask is the role of endoscopy in the last years. Then came endoscopy for anterior skull base meningiomas. And I don't know, Professor Anil, what do you think about endoscopy in anterior skull base meningiomas? And is it less invasive or more invasive than a simple eyebrow incision?
I think we have to be very honest about CSF leaks, and that's why I make it a point to publish my series and say, listen, you need to get, no CSF. So my 180 cases have 3 CSF leaks. Yeah, 1 required a cranie. We have to be very meticulous about that. Clearly, the CSF rate leak is high, but if you have a 9 centimeter anterior base meningioma, you're not going to get those tumors out endoscopically. You can debulk them, and I've seen some of their debulking for 80, 90-year-old patients. I think that makes sense. I think the endoscope for craniopharyngiomas for small midline tumors is definitely good. I've used it. I like it for clivus chordomas. My preference is still to go from the top, but I think the age, it's how a new school comes up and they're really good at it. I mean, you talk to Lunsford, they're going to say, this is the only way to go. If you talk to Paul Gardner and the endoscopic guy, oh, this is the only way to go. So I think we just need to take it with a grain of salt. But I think it's a great advance. But I don't think we should use it blindly for every case. I think that judgment is still very important. Yeah.
I completely agree. What about the traditional approaches? Because we were trained, and I have seen from the series that rarely you do a petrosal approach. You do.
Yeah. I moved away from petrosal. I just think, you know, I can take out a petroclival meningioma in 3 hours. With the traditional approach, I'm like, do I really want to do a petrosectomy and do all that? I still do petrosectomy in very select cases. Just like the far lateral, I don't drill out the condyle. I think as you get older, you become more of a minimalist. You know, you're like, get the patient, do well, get in, get out. You don't need 14 hours under the microscope because that's never good for the patient. Yeah.
Okay. And what about the orbitozygomatic? Do you still?
Oh yeah, I still do OZs. I mean, I think OZs
OZs.
easy thing to do. OZ doesn't add much morbidity. I do that a lot of times. I might do a mini OZ or just take the roof off. I mean, I think that's perfectly reasonable.
So this is one of the approaches that stood the test of time beside the classic.
Correct.
Okay. Thank you very much. I really enjoyed this presentation. And I still thank Suad and Nagia for inviting me. Thank you. And
you're welcome, as always, Dr. Hussein.
Okay.
Gia, you have the talk, please. Micro.
Yeah, of course. Thank you, Anil, for this really very, very interesting and outstanding talk. And beyond of, as Abd-Samad and Hussam said, beyond of the skills of the surgeon, beyond of the, of course, of the experience of the surgeon, of the number of case that you have done, I think you say something very, very interesting. It's of course fully with wisdom and good sense, and it makes sense for us when we have to, of course, when we have to give. If we, my question, of course, is if you have to give advice for young neurosurgeon about the combined treatment. I mean, as Samad and Hussam said, it's about when you have to stop surgery in some cases, because for young neurosurgeon, maybe he said that he give them lazy, but we need to give them also advice when they need to stop surgery and to of course lead some residue for gamma knife. If you have some take message home for young neurosurgeon, thank you.
So I agree, but you know, the paths to wisdom, Nagia, you've clipped a lot of aneurysms, you look back and say, oh, I should have done this. And I think the path to wisdom is a very lonely road. We all have to go on that road. We can't take you there. You know, I did an AVM on a 4-year-old girl on Thursday, okay? She bled once before in Beijing. She bled. She had a blown pupil by the time I saw her. Rushed her to the OR, took out the thalamic hematoma, took out the AVM. The brain was relaxed. It looked beautiful. ICPs went up. She was brain dead 3 days later. This happens in the best of hands, whatever we do. And I think that road is a treacherous road. It's a lonely road. But it's also not a road you can guide people, okay? This is the speed limit. But I also think wisdom comes to us with experience. And without experience, you don't get wisdom. Yeah. I also think for the younger generation, you have to push technical perfection. You know, you have to do 100 rat carotids and do the bypasses. You know, I think that technical quest is very important. And I think the most important thing is joie de vivre. You know, I can't believe they pay me to do this. I love this so much. And the only piece of advice I'd give a young neurosurgeon is, you gotta love what you do. I mean, every time I split the fissure, I still say, wow, I'm lucky to do this. You know what I mean? And I think that in the sense is where we all worship at at the altar of technical excellence. You know, we aspire to be like Majid Sami, like Spetzler, like all these great surgeons. And it takes discipline to get there, and it takes dedication. And what I find with younger neurosurgeons, there's no shortcuts to fame, okay? It's not like, I want to do this, I'm going to be famous. I'm like, ooh, you're doing stuff you probably shouldn't be doing. So I think that road to wisdom, it's a lonely road, and we've all been on that road, and we've seen, I mean, I remember a patient when I was 3 years out in practice, Monica Harris. I clipped a PCOM on her. She had the most beautiful green eyes. She got into spasm and she died. And you, all of the senior people, we just remember our disasters. We triumphs, because triumph, oh, they do great, you love everybody. The ones you lose, they're the ones that make you a better surgeon. They're the ones that humble you and give you caution. And that's a lonely road, you know. I mean, that's all I can tell you. Enjoy what you do, be careful, and yet push the envelope.
Thank you. There's a tear and smile in neurosurgery, always.
Always, always, you know.
Thank you. Nabila, I think that we have some questions about, in the chat.
So he operated 465 vestibular schwannoma, including 65 cystic, and facial nerve function is often poor in cystic vestibular schwannoma, despite the anatomical preservation of facial nerve. What is your experience in cystic vestibular schwannoma and postoperative facial nerve function?
So I don't have that large a series on acoustics. I think mine are about 300. With cystics, I've actually been quite lucky because I like the dissection. You know, it opens up very nicely and you decompress, and then you can find the facial nerve. But, you know, I've had acoustics that were gamma knifed and then grew monstrously. And then it's a disaster. Actually, for a longer talk, I have the slides on that one. So I think, you know, you're right. I mean, I think that varies. And it's interesting, Lunsford had a paper with my new faculty member, Stephen Johnson, where gamma knife, it was actually a very good predictor. Cystic acoustics do better with gamma knife because it shrinks the tumor completely and the cyst goes away. So that's just another thought on that.
Thank you.
Thank you. Is Professor Belibna with us now?
No, I think he has a problem with his...
Always a problem? Okay. Yes. I just want to make a comment, Anil. Of course, I'm not dealing with skull-based surgery. I'm dealing mainly with pediatric, but you have said two key words, which are wisdom and humility, to be humble when we are faced to the disease. And I think that this is the best message that we have to give to our young neurosurgeons, because sometimes they are very exciting about technicals, about, you know, I've done that, but I have to say that we are faced to a patient, to parent of a patient, and we have to ask, what did you expect about that? And you said something really that when we get experience, we get wisdom. And I hope that all neurosurgeons will get this wisdom, because, you know, sometimes we see things in presentation, in some articles about, I don't know how we said in English, but in French we said prouesse technique. But the problem is, what is the patient after what you do? And I think that when we are teaching to our young neurosurgeon is this philosophy. And that's why I like your presentation, because you are always talking about this philosophy. We have to be there. We have to have a wisdom. We have to think about what will be the future of this patient. Thank you so much for that. Professor Abdenbi.
Privilege.
Thank you, thank you. Professor Abdenbi, do you have to ask some persons of the panel, or?
Maybe one question or two for Professor Anil Nanda. What's your point of view about the endoscopic approach or the microscopic assisted endoscopic approach?
I always use the endoscope if I need it. I'll look around with it. I like it for clivus tumors, but even routine stuff I'll bring. I think we just have a paper coming out where we did a trigeminal schwannoma and we used the endoscope to look inside. And sometimes a blind angle, you can't see that well. So, I mean, I'm all for those things. The problem I have sometimes with technology is when people say, this is the only way to do it. It's almost like religion, you know, when they tell you this is the only way to salvation coming on our road. I'm like, well, maybe, maybe not. You know what I mean? So I think the same thing with there's zealots in neurosurgery, and they will say this is the only way to do this, and everybody else is sinful. And I don't agree with that. I think we have to be open because, you know, we've all had our complications, and even, you know, and I'm all for using the technology. For MVD, sometimes I'll use a scope. It helps you look around corners, and I encourage that, you know, as long as your results are great, I'm all for that.
Another question, do you use some drops of papaverine when you are to avoid vascular spasm?
I just did an unruptured middle cerebral artery aneurysm, 48-year-old lady. It was a small aneurysm, but she may have bled. I always use papaverine for unruptured aneurysms and ruptured aneurysms. Now for tumor surgery, I do ICG. I like to make sure the carotid is open because sometimes you get a stroke post-operatively. You want to make sure the vessels are fine. So I like ICG a lot, and I think that helps a lot. Yeah.
Thank you, Professor Nanda.
From the panel, Professor Azhari or Professor Hussam Al-Husseini, do you have other comments, please?
Just one question, which is really very philosophical, but I don't know if you have some idea about predetermination and why people choosing skull surgery and vascular surgery to suffer all his life in this surgery, and another one make spine surgery, and who is spine surgeon with many advantages and not a lot of stress. Do you believe to do the predetermination, Anil?
Oh, I agree. I think if you look, I tease the radiosurgeons, they're going to live forever, okay? In radiosurgery, you don't go to an ICU. You never have complications. You tell the family your patient's brain dead, all this thing went bad, okay? I mean, I think our risk for cardiac disease is exponentially higher. Okay? Yeah. Now, if you're only doing ACDs in the spine or lumbar laminectomies, also your risk is very low. So, you know, it's like some people want to be astronauts, some people want to be fighter pilots, the other people want to fly commercial. So it just depends on your calling. You know, some people like the risk. You know, I kind of gravitated towards skull base, and I feel very blessed. But I still like doing spine. In my career, I did 2,200 ACDFs. I used to do like 6 ACDFs a day because I thought it was recreational. It made me feel so relaxed. It was like playing a round of golf or something. You know what I mean? Not that I play golf, but I agree with you. There is some predetermination. But I think one of the cautious things I say is that younger people, and Saud, I would agree with you on that, they want to get famous quickly and take shortcuts sometimes. And that's where I've had the biggest problem mentoring some people. You know, they were like, nope, I can do this. I'm really good at it. I'm like, ooh, your results aren't that great. You should have, you know what I mean? And that road is a treacherous road. And if they're not humble, they'll never learn. Mm. They will never learn, you know? And you know it, some of the giants in our field will never discuss complications. They publish series and they make you think that we are divinity. In our hands, complications don't happen. Complications happen only with other mortals. And I've always gotten upset with that. I was a young attending. I went to the senior society meeting And a famous neurosurgeon said on acoustics, all my acoustics go home on post-op day 2. I'm like, my patient is still in the ICU post-op day 3. I'm like, I'm that bad? And I'm like, this is nonsense because I know it's not true. You know what I mean? So sometimes we get into this marketing / advertising thing that we want to be the Pete Sampras or the Roger Federer. And we're like, well, we never lose. I won Wimbledon all the time. I'm perfect. And the truth of the matter is, I've been to all the great ICUs of the world. And you go to these ICUs and they have the same complications you and I both have. We'll see an unruptured aneurysm, got it hemiplegic. I mean, these things happen. And when they tell you they don't happen, I don't agree with it. I'm like, nope, everybody gets complications. You know,
I ask you that because I see every time that people become wisdom, because you said it's experience and technical. It means that we can become wise man. But what I have as a remark is that everybody do vascular surgery, skull-based surgery, become wise man because of the difficulties he made in his life. And I think that for our young neurosurgeons, they will grow and they will be wise men, but it needs a time, because every brain has its age, and the young people have its age, the brain of its age. So he's not in the concept of wisdom. He's in the concept of going on.
It's the quest for glory. You know what I mean?
Yeah.
Achilles in the Iliad, they said you can have a long life, but nobody will ever know you. Or you can have a glorious short life and everybody in history will know you. That's what he decides. Well, I want to be known. And they once asked Olympic athletes, if we could give you a drug that you knew was illegal but could never get detected, and it would take 5 years out of your life, but you would get a gold medal, do you know how many % of the athletes said we would take that drug? %.
Yeah.
That's the problem. The thirst for glory at all costs. Younger, that thirst is insatiable. You're like, oh no, I want to be, I want to be like Taylor Swift, or I want to be the pop star.
Thank you, Anil.
Professor Hussam, do you want to add something?
We are in the philosophy now.
Yeah,
I know.
But it's very important, in education, I think. I think that we suffer from a lack of philosophy and of wisdom in our education, in our program of educations. I think we have a big lack in this. Professor Hussam, do you have something to say?
Yes, I really enjoyed Professor Anil as a great surgeon and also as a great philosopher, because he spoke a lot of philosophy and the glory. It's a pity that I don't know if it's also in the States or in Algeria or in Morocco or in the Arab world, that the young neurosurgeons are going more and more with spinal surgery. They don't go to the glory of skull base. It's with more complications and tedious. And as you said, you need your curve. You need a lot of years in order to build up experience and curve. And at the same time, the money comes, as they say, from the spine, from the back, from the screws and from the, so we hope that we don't lose such a subspecialty in neurosurgeon with, as they said, the gamma knife. It makes you yeah, and we have now in Egypt, I don't know, it's staged gamma knife for big tumors, and they receive a lot of cases. So they do big petroclivals in 2 or 3 sessions. I don't know if this is right. And you convince the patient, or the surgeon convince the patient that this is safer. And then you have a bigger problem, because after gamma knife, you have more adherent tumors, and the arachnoid planes are more difficult to dissect. So we hope that everybody will take the philosophy is to remove, but still be careful not to injure. So is that is that going anywhere else in the Arab world? I'm sure it's not in America, but I don't know how it is in Algeria or in Morocco, where you have staged gamma knife for large meningiomas or even acoustics.
Najia, could you answer for Morocco?
I think I can give the answer about the Moroccan's experience. They are staged now more and more staged gamma knife, because the last machine that they have, it's more accurate and more dedicated to this, the staged, of course, the staged cases, but not for big or huge tumor. Of course, there are limits, of course, for this. And the indication there, when there is contraindication for surgery, of course, about the age or some ills, at that time they indicate the staged gamma knife, not when they can, of course, do surgery for huge tumors.
So the question is, what do you mean by huge tumors or large tumors? Is 5 centimeter large? Is 3 centimeter large?
You know,
6 centimeter large?
The usual dogma that was 3 centimeter, but now I think they can do it. I'm telling about some cases, special cases when there is a contraindication for surgery. In these cases, of course, symptomatic, very symptomatic cases, and there are contraindication for surgery. In these cases, they indicate a staged surgery. But there are staged surgery also for almost 3 centimeter. But for more than 4 or 5 centimeter, if there is contraindication, it indicates staged surgery, not before. And it depends
for Algeria.
Typical stages, more than centimeters of tumors.
Okay. I can answer for Algeria. The problem is simple because we don't have till now radiosurgery. So we are dealing always with macroneurosurgery for this type of tumors. Till now, we don't have radiosurgery. I hope that we will have it in the next future.
Stages, more than centimeters of the tumors.
Okay.
We have the latest, actually, we have the latest gamma knife in Egypt. 2, the last versions. 2 gamma knives in Cairo, the latest version, but still, I don't believe that they give
the icon, because the last one is the icon.
Yeah, we have 2.
The one of is dedicated to the staged, not before the prefixing. No, it's not possible to do a staged surgery with radiosurgery with I don't know. I don't know if it's. But
and what about Professor Anil?
It's possible to do
staged gamma knife. I think we have the precision, what they call the precision gamma knife.
We used to do staged gamma knife for large grade 4, grade 5 AVMs. And then the paper came out, said you really don't help them, so we backed away. But I will tell you, I think one of the concerns you raise about the art dying, so you look at Europe today, 90% of the aneurysms are coiled. So the clippers are a dying breed. So all the failed aneurysm coiling, and I forget the name of the guy in Paris who does all the, like he was at the World Federation meeting and he said all AVMs should be onyx. Through the venous system, we can cure AVMs. So I worry when that happens, the skill set goes down. And that's worrisome because where the next generation of surgeons going to come from? You know, I was very fortunate in my career. I clipped over 1,000 aneurysms. You know, for somebody to accumulate 1,000 aneurysms, this coiling now, it may not be possible. So I just worry a little bit about the art because the aneurysm we're going to get are going to be very difficult because they're failed coil ones. And same thing with tumor. You're going to stage gamma knife. You go in to get that petroclival meningioma, it's going to be very difficult. You know.
I think.
Professor
Sorry.
Bakhti,
Monsieur Abdenbi, sorry, 1 minute, please. I just want to give the talk to, he's not in the panelist, but I will give him the talk, Professor Kliba. Professor Kliba is head of department in Bijaya, which is a town at near 250 kilometers from Algiers, and he is a member of the Education and Training Committee. So he wants to ask a question. Suhail, are you here, please?
Yeah, thank you, Saad. Thank you for all panelists. I'm in the kitchen. It's my favorite area to learn. What are you
making, baba ganoush or hummus?
Then I have one question, only one question. It's very risky and challenging surgery. Did you simulate the technique before surgery?
No, I haven't done that. I do skull-based dissections. In the past, when I would be going through a difficult case, I would do a petrous bone dissection. I did do, when I was younger, I used anatomical dissection a lot. And when I was with Janetta, I would go, and every day I would do a rat carotid anastomosis. And I thought that technical exercise was very good. But I do agree with you, simulation will be a good way. You know, even to sort of open an orange or try to stitch the arachnoid or take a glove and use stenoprolines to stitch, that gives you very good hand-eye coordination under the microscope. And I do think you need hours and hours of that to make you good. And we need to stress that because it's not something you can just do and say, oh, I can do this. I saw one, I'll do one, and I can teach one.
Okay, thank you.
Thank you.
Thanks, Suhail.
Professor Abdenbi, if you permit, I would like to ask Professor Bouyousef if he has any comment because he is with us. And I will give you after to make a conclusion, you and Professor Najia. Monsieur Bouyousef, I think he's not here. Are you here?
No, I am here.
Yes, please. If you want to make a comment, please. Professor Bouyousef, sorry, I just have to introduce you. I know that maybe Professor Anil Nanda know you, but Professor Bouyousef is one of our dean in neurosurgery in Algeria, and he is a master in the field of neuroendoscopy in Africa. He introduced neuroendoscopy in Algeria, and many training has gone to his department. So Professor Bouyousef, it's to you, please.
Thank you very much, Suad. Really, it was a very nice webinar. Thank you, Anil. The subject was very, very difficult, and you have this faculty to summarize a very difficult subject in terms very, very simple for us. Thank you very much.
Thank you.
Thank you, Suad, and all the committee of Neurosurgical Arab Pan-Arab Society, Najia, Hussam, all my friends. It was very nice webinar. Thank you very much.
Thank you. And we
Professor
hope to
Abdin
meet-
Beats to you, please.
Yes, thank you. Professor Nanda, today we talk about proton therapy for cases with partial resection, not only radiosurgery, but proton therapy. Have you some words about this technique?
So we have proton therapy with us. My experience with this, especially for glioblastomas, has not been good. So we had a proton therapy. The incidence of radionecrosis is higher with proton beam for intraaxial tumors. So I had a young girl, we did it, and so it kind of concerned me. But proton beam may be good for skull base. I've sent several cases for them, but long-term data is still not published. I think one of the advantages of Gamma Knife, especially with Lunsford, they published a lot, everything. So they'll tell you, oh, CyberKnife is the best thing for you. But there's not that much published with the CyberKnife. You know, the one thing with Gamma Knife, they've got really good data. So I think that makes it a little more, I'm sure it works just as well, but I think having that data published gives us more credibility.
Thank you. Thank you.
Thank you. Najia, could you say some words to conclude, please? I think that we don't have any comment or any questions.
Okay, thank you, Suad, and thank you very much, Anil, for this really outstanding talk. We enjoy it a lot, as all our friends said, and it's spectacular as usual, and a lot of philosophy. And we know when Suad told me about this webinar, I know previously that it will be more philosophical than scientific, of course. And I would like to thank all the panelists. There were especially my friend Absamad, Hussam, and Professor Abdinbi for their comments, very interesting comments. Absamad, I appreciate very much your comment this evening. You are also philosophic. I know we are the philosopher of Moroccan neurosurgeon. And thank you, Suad, and all the Algerian society to give the opportunity to all the pan-Arab countries to be here with you today. And congratulations, and go ahead. You are done a great job, and many thanks for this excellent webinar. Thank you. And thank you for all the attendees for this evening. And get with us as earlier at this time. Thank you.
Professor Anil, we hope to see you in Cairo when it's opened. Were you there before?
Yeah, I've been to Khan Khalili. I took a bus from Cairo when I was a resident in Queen's Square. I was doing neurology. That bus from Cairo to Jerusalem, and I went to Sharm el Sheikh. So I scuba dived there.
Things changed. We are opening the new museum. It's I think it's the biggest in the one of the biggest in the world, like the Louvre. And we hope that with the COVID disappear, that you can give one of these excellent presentations to our young neurosurgeons and to the neurosurgeons in Egypt in general.
I was privileged to be here. Thank you so much. And I must tell you, Saud and I have known her for many years, and I used to always tease her. Her last name is Bhakti, which in Sanskrit in India means devotion. So I always tell her, you're so devoted to neurosurgery. So merci beaucoup. Shukran, shukran, alhamdulillah. Thank you very much.
You know, Anil, I always, when I know you and you say to me, your name is devotion, you know, I always repeat, I have a friend in the United States that said to me, my name is Sanskrit is devotion. And I hope I will devote it to neurosurgery all my life. Thank you so much, Anil.
Thank you, everybody. Be safe. Thank you so much for the privilege. I really appreciate it. Thank you, guys.
Thank you.
For this
Thank you.
outstanding presentation. And thank you to all the panelists and to all the participants.
and hope to see you.
Small word, please.
Yes?
Yes.
You have the conclusion. Thank you.
Yes.
Okay.
I think we can't conclude. Professor Nanda was thanked, but our two madams, Madame Professor Bakhti, the president of the Algerian Society of Neurosurgery, and Madame Najia Al-Abadi, the president of the Pan-Arab Neurosurgical Society, do a very, very big work. And I'm sure the men before them didn't do this work. Maybe the work was facilitated by the COVID.
I think we call them, whether Suad or Nagia, the Iron Women in neurosurgery. I don't know. I
like
don't know.
Margaret Thatcher, like Margaret Thatcher.
Yeah, the Iron Women.
Iron Woman.
Bye-bye, everybody. Thank you.
Bye-bye.
You have participated to this webinar.
Bye-bye.
The webinar is on the 6th August with Professor Concesio Di Rocco about intramedullary tumors in children. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye. Bye-bye.